Hey. Hey there. Welcome to TWIRx. It's good to feel you out there, the vibes. Put the vibes out. Put the old TWIRx vibes out there. How was your week? I hope it was well. I hope you're doing things that give you passion. I hope you're working somewhere, doing something that brings you happiness and being part of something bigger than yourself and helping others. Our world, our country seems to be really in emotional hurt right now. And it's my fault. It's my fault for not being understanding. It's not my fault for not listening. It's my fault for not making someone feel cared about and valued. And isn't that the basis of what healthcare is? It's making people, helping people, not making people, helping people to make decisions along with you as someone that can guide them. In this case, in our medication worlds, and making sure that they're cared for, making sure that they're heard. And that starts with that relationship between physician, patient, and pharmacist, patient, and for them to understand where the strengths are of their physician, where are the strengths of their pharmacist. You know what we have to do? We got to get the message out there more about what pharmacists are doing. You know, when you look at the Pharmacy 50 awards list, there are more than 6, I think I've counted them, are all social media influencers, huge into TikTok, huge on Instagram, big on YouTube. This is important, and this is what the Pharmacy Podcast Network is all about. For 17 years, we've been delivering the latest news and what's happening in technology, what's happening at Cardinal Health, what's happening in maternal health with Dr. Danielle Plummer. We had a really special Valentine's Day special with Mark Garofoli and Gretchen Garofoli, both PharmDs. Yeah, if you haven't listened to that, listen to that. And then herbal support for chronic Lyme disease. This was really super duper interesting. I did not know. And just learning more about the dangers of Lyme disease. We have a lot to talk about today. And I'm going to be in Harrisburg today. So be on the lookout for Pharmacy Podcast Network. We're going to be at the Pennsylvania Pharmacist Association meeting, the PPA 2026. It's the Super Bowl of Pennsylvania Pharmacy. We're going to be there with a special tribute and coverage of the Pennsylvania Pharmacist Care Network, the consultant network that's a pull, which is the chapter of the CSPN national network, to do more treatment driving and clinical care and clinical follow-up, and really making pharmacists plug deeper into a patient's life. And I'm going to be proud to be there, proud to talk with them, proud to be a Pennsylvanian, and going to the Super Bowl. The Super Bowl of Pennsylvania Pharmacy is now happening 2026, February 20th through 22nd in Harrisburg. It's going to be a fun time. Shout out to John DeJames. He's my good friend from Value Drug, and their support of TWIRx, as well as their support of the Pharmacy 50 Awards. It's nice to have the support from organizations like that so that we can get more messaging out. And if you're listening and you want to work with us, I tell you what, It's fun being the #1 podcast in the entire pharmacy profession from a world perspective. How many people just reached out to us? We have several features coming out of London. We have a collaboration coming back out of New Zealand, Australia, Ireland. So we're growing. It's expanding, and they're the voices of pharmacists on a global scale. We need to support each other more, talk with each other more, and more importantly, learn from each other. Today's TWIRx, February 20th, 2026, is brought to you by and sponsored by RX4Route. If you've never heard of this platform, you're going to hear from us. We're going to be talking about it a lot. And we're going to be talking. The more important aspect of talking about RX4Route isn't them necessarily, but more importantly, it is all about the long-term care pharmacy services at home that's expanding. And a big part of long-term care pharmacy at home and the expansion of independent community pharmacy, the world of the outpatient pharmacy that is involved with our hospital systems and even grocery store chains. You have to get into the delivery, and doing it yourself is a lot more expensive than outsourcing it to an organization that's going to be plugging into drivers all across the country. Check out RX4Route and be on the lookout. We're going to be interviewing the CESO, the Chief Sales Officer, my friend Doni. That interview is coming up. But I do want to do TWIRx news. It's probably my favorite part of TWIRx. And I'd like to start off just saying congratulations to the Pennsylvania Pharmacist Care Network. They're celebrating 10 years of being the Pennsylvania Pharmacist Care Network. They couldn't have made it there without the contributions of numerous indispensable partners, but are grateful to our 10 over 10 partners that have elevated the PPCN to the network it is today. Wow. Once again, this is why I'm so excited about this coming weekend and being out at the Pennsylvania Pharmacist Association annual event. Like I said, if you're going, let's hang out. Let's get together. Not sure if you're going to be there, but would love to see you. Would love to connect with you. Hey, up on TWIRx news, you gotta read this. This is fun. University of Kansas School of Pharmacy has covered this, and they have alumni, and they've supported the advancement of oral testosterone replacement therapy and what this means for patients, and what this means for options, and being able to cover what they're saying, a clinical problem hidden in plain sight, and how testosterone is widely prescribed, and then what issues is that only 1% is actually making it to the bloodstream through the oral dosage, and how when you take oral versus it absorbing into your skin, even sildenafil getting into your system through now the new strips they're coming out that you put underneath your tongue, and it just gets into your system differently and also gets into your system faster. And then a much larger percentage of the substance is also reaching the bloodstream. Read up on that. This is news from ku.edu. That's news.ku for University of Kansas. And it's their School of Pharmacy. But check that out. They should be so very proud. All right. We have news coming out of Pharmacy Practice News. I love this organization. I love the paper. We hope to see them at the Assembia covering specialty pharmacy. But today's article is how to handle live therapeutics despite the lack of guiding document. How to handle the biotherapeutics and the biosimilars. And they're saying when there's, despite the lack of guiding documentation, we do have an interview coming up with a medical writer I don't want you to miss that. Kirsten's going to be on, and I want you to read this. Go to pharmacypracticenews.com and read through the issues that they're talking about. 38% of those are in vivo mechanisms, and about 58 of them are in late stage research. And that's the amount of information, that's the amount of research that's going into new therapies being researched and being gone through clinical trials and getting them out there. The American Society of Gene and Cell Therapy, third quarter of 2025, more than 3,200 gene, cell, and RNA therapy clinical trials are underway worldwide, reflecting the sustained growth across viral sectors of cell-based platforms and novel delivery mechanisms. Do you know, with the advent of the new world of pharmacy, where pharmacists are going to be doing a lot more than dispensing medications and really dialing in. Anyone listening that is fascinated by biosimilars, reach out to me. I have some connections for you to get you to the people who are helping to actually build that entire sector of pharmacy. But if you're interested in biosimilars, if you're interested in talking about it and what the future is for this and how pharmacists play in, as in my opinion, you should be the experts. But let's talk more about that. Last, but certainly not least, one of my favorite magazines is here, and they're talking about pharmacists' help, importance of food is medicine for American Heart Month. I love this story. Just came out today. Food as medicine differs from general wellness in embedding therapeutic nutrition into clinical pathways via medical tailored meals, medically tailored groceries, and produce prescriptions for conditions like hypertension and diabetes. You know who talked about connecting nutrition with a grocery store tracking system? You know, your Advantage cards, like here in the Pittsburgh area, we have Giant Eagle. They have the Giant Eagle Advantage card. Can you imagine? I've said this at least 10 times on the Pharmacy Podcast Network. But can you imagine, you know exactly what your patients, aka consumer, is buying, because if they use their Advantage card, you have all that data. We pull some of that data when applicable. So when the patient now gets on some kind of medication within the pharmacy, you sign off on all the legal documentation, letting you know that you're going to be exchanging data between departments. And now you send the data from all of the produce that they have bought, any of the recommended herbs and spices and substances that has been recommended by nutritionist-driven pharmacists. And now you're assuring, based on what they're buying, that most likely they're also consuming it. You have to assume. And with that, you could help to control and supplement medications that the patient's on. I'm not talking about anything that isn't in motion already. I'm sure that these people are thinking of this, but this article really drills down into what is the opportunities for pharmacists. We just got done talking about biosimilars. We know there's senior care, pediatrics, now nutrition, changing people's lives metabolically, physiologically, and pharmacologically to assure that they're in the best shape that they can be in, based on decisions, once again, that they make, and then helping them to track that. But this is a really interesting article out of Drug Topics, and shout out to the team over at Drug Topics. Once again, it's Pharmacists Help, Importance of Food as Medicine for American Heart Month. Good move, good move. I love it. All right, so I'm going to see you in Harrisburg if you're going to the PPA 2026. If not, I think we will see you. I don't know what is next for us. I'm boggling my mind, but we know we're going to the Pharmacy Profit Summit. That's all about building profitability and sustainability and thrivability for independent community pharmacies. Profit Summit Live. Google that, Profit Summit Live. 2026 Profit Summit Live. It's going to be in Dallas. Take a look at that. Understand it is a change maker in the business of independent pharmacy, because all of these independent community pharmacists show up and everybody throws into the pots when they're networking. What are you doing to make money? What are you doing to make money? How are you doing it to make money? How are you providing value to the community while making money? You have to make money. And this place is absolutely what it says it is. It drills down into the profits of pharmacy. So hope to see you there. We are excited about today. Like I said, I want you to take a listen to my friend Doni with RX for Route. We will be right back.
Running a pharmacy means juggling a lot. Patient care, inventory, and now compliance. That's where MatchRx comes in. MatchRx is an online marketplace where independent pharmacies buy and sell their overstock safely, quickly, and affordably. You can also shop from 11 plus trusted secondary wholesalers, all in one place. We're here to make pharmacy ownership easier, connecting you to savings, trusted partners, and simple tools that help you stay compliant with confidence. MatchRx, where pharmacy meets trust, compliance, and opportunity. Visit MatchRx.com to learn more. That's MatchRx.com.
Hey, welcome to This Week in Pharmacy. Todd Uri here. Hope you've had a good week. It's been a fast week for us. We are headed to the Pennsylvania Pharmacists Association today, and we'll be there tonight to celebrate the 10-year anniversary of the PPCN. So what is the PPCN, Todd? Well, I'm glad you asked. The PPCN is the Pennsylvania Pharmacist Care Network, and they are basically taking what CPESN, our National Enhanced Services Pharmacy Network, is doing. CPESN, look at all this alphabet soup. And they are working and teaching and coaching and supporting each of the states. And some states do a better job based on their aggressiveness for the program through the pharmacy state associations. And then there's other ones that are maybe wrapped up in something else that they just don't have time to push it to the state. Pennsylvania, very proud to say this, because I am from the great state, the Commonwealth of Pennsylvania. But our state is one of the best at leveraging the CPESN strategies, care plans, saving money to the plans, building partnerships with the healthcare plans. That's exciting. So we're going to be talking a lot about that at the event. So even if you're not from Pennsylvania, even if you're not going to that national event, I'm giving a shout out to the PPCN. It's their 10th anniversary since building this network of pharmacists, digging into clinical, digging into treatment in the state of Pennsylvania. Bravo to you. But we will have a multi-part series talking with some of the experts in Pennsylvania, so you're not going to want to miss this series coming out. But today on TWIRx, we're going to be talking about one of my most favorite subjects, because I want to see more of this taking place. And what is that? Well, that's long-term care pharmacy services at home. Long-term care pharmacy at home, I guess they're calling it, used to be called Combo Shop, but now we're really becoming much more granular about getting paid for the services that you provide as a community pharmacy, as an independent community pharmacy, as a health system outpatient pharmacy, that they're getting into this, taking the patient from the emergency room to the ward of recovery in the hospital, making up the medication list, transferring that medication list out to an independent pharmacy, a consultant pharmacy, a long-term care pharmacy. Who knows? It might even be specialty depending on the patient. But part of that ecosystem, the focus of today's TWIRx, is inviting back an expert and a friend of mine who I'm excited to bring back, Doni Sattarov. What's the last name? Doni Sattarov. Is Sattarov?
Sattarov.
Sattarov. I have to have the little accent in it. The Sattarov, right?
Yeah, the Russian accent.
Exactly. So welcome back to the show. It's good to see you.
Thank you, Tat.
All right. So I know you guys aren't able to make the Pennsylvania one, right? You're not coming this weekend.
Unfortunately, we are busy with the NCPA conference, the
Oh yeah,
multi-store
yeah.
location one.
A multi-site. Yeah,
Yep.
shout out to everybody going to the NCPA multi-site. What a special event where they're really focusing on strategies for these organizations that have 5, 10, 20, becoming like these small regional chains and empowering them. I love that conference. That conference for me, the reason why we don't concentrate on going is I don't get enough exhibit time to network and to be able to really build content because their exhibit space there seems to be such a shorter span of time than other places. But then I think they do networking at different what I don't know. I haven't been there since 2018. So you tell me.
I know this one is more about quality than quantity. You do have couple, I would say it's a couple hours at most to exhibit per day. That's if you're lucky. But the quality of the pharmacies, the people in there, it's not mixed with the crowd, it's not mixed with the students. It's just exactly what we need for us.
That's funny because it is like the cream of the business crop. These people don't have any time to mess around, so they're
Yes.
searching for solutions and they're ready to make deals. And so I see what you mean. Hey,
Yep.
today we are talking about long-term care pharmacy at home, and there are different components of that. And you know this, Donnie, because you're soaking in it. But we have regulatory compliance, we have workflow changes, formulary potential changes, medication regimen controls, and different things that have to happen. An emergency tackle box. You have to have a tackle box of like emergency meds, the ability to get 24-hour emergency assistance. And then the key today of what we're really dialing into is how important delivery is to this ecosystem of what is long-term care pharmacy at home. And here's the deal, and I don't know if the listeners, you might not realize this, but seniors are lacking transportation, and they're often facing really significant boundaries accessing medications. Lots of pharmacies, Donnie, have been closed. Over 8,000 pharmacies are not here that were here 2 and 3 years ago. Transportation issues are causing 30% increase in medication non-adherence, and that's infecting 3.6 million Americans. So the 3.6 million Americans are missing out on doses of medication that they need, which is tied back to ding, 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 transportation. So talk to us about how your organization is coming at this from a very strategic perspective, where you're not just trying to sell a delivery service, you are trying to integrate this system into workflow, into pharmacy systems, into the whole business model so that you can help those pharmacies be more profitable. So talk to us about this.
Absolutely. So we, starting off, we started as just a software company for managing your deliveries, right? We worked very closely with multiple pharmacies, specifically once the long-term care at home became so popular. We optimized our system into making sure it helps you to finish the chain at the end, right? Making sure that all the refills, all the 30-day, all the cycles are on there within those patients in the RX for route delivery system. So not only it helps your drivers to stay compliant, to deliver everything on time, to reduce the errors, but as well as it helps your pharmacy to stay and be more profitable, stay on top of every medication you send out.
You know, I used to rep business development, sell pharmacy management software, Framework LTC.
Really?
And yeah, that's how I started in the pharmacy industry. You might not have been born. I'm scared because you're so young. 2004 is when I entered pharmacy, and I was brought in because I had a workflow background. I set up frame relay networks in the telecom space, and I would sell frame relay and manage networks. And that type of concept back in 2004 was so novel. Nobody was talking about workflow. So when Framework came out with their pharmacy management system, it was based on SQL. It allowed for the integration and pulling and pushing of data in and out of the system. It wasn't necessarily the primary software, because back in that day, Donnie, every one of the freaking softwares back then were closed. They were like, you could put in information just in the system. You could get a label out. That was it. You couldn't extract. You couldn't put in. So what I think is interesting is now we're at the age where it's the community pharmacy and independent pharmacy and local chain pharmacies, like even grocery store, that when they start dialing into long-term care pharmacy at home, it opens up a whole new profit center and revenue opportunity for them. But they have to talk about it. They have to let the community know what they're offering. They have to advertise that they have courier service, delivery service, logistics service, timing, application, handheld app, like engaging the public. Like, it's not just about the tech, and it's not about, putting it in place. It's really about making it part of your whole business every day. You're talking about it.
No, absolutely.
Do you have stories about the integrations? This is so important for listeners. They're like, hey, yeah, I want to move forward with long-term care pharmacy at home. I've brought up my policy and procedures. I got my pharmacy software ready, the workflow. Talk to me about working with other pharmacy software systems.
Sure. So RX for Route integrates with all major pharmacy management systems, and it's a two-way integration that we have. Not only nowadays we can retrieve the data from pharmacy management system, but we can also send it back. With the information that we collect, especially for the past couple of years, we've made some edits in TWIRx that is now fully optimized for specifically for long-term care at home pharmacies, combo shops, quote unquote, where not only the patient's information is retrieved, but as well as the next filling date, next cycle dates. And within our system, the reason why it so differentiates between us and any other delivery system that you might have come across is that we're so optimized within the cycles where our system tells you what is the best profitable, efficient way to schedule your deliveries, knowing all the information regarding the cycles.
That is so cool. Yeah, because as a long-term care pharmacy, there are these, I don't think they do 7-day anymore, but like 14-day, 28-day, 30-day maintenance meds. Like, there's all these things that are in place for our long-term care facilities, our assisted living centers, even some just simple care. But now when we're starting to bring this to the home, that's a lot of complexity for, from a delivery perspective. So knowing that you have 30 homes, that might be a low number, but let's say you have like 30, 40 homes in a 5-mile radius, each of them need their updates on their basic DME supplies, durable medical equipment supplies, but then their medications go out just slightly differently in a schedule. So what you're telling me is you're really dialing into that and coming up with the most efficient way of getting those deliveries done.
Absolutely. And it's a good thing you've mentioned DME, durable medical equipment supplies as well, is that now we integrate with almost all DME management systems.
What about there's been, I remember back in the day when I remember the expansion of people getting services at home. Matter of fact, my grandfather was in a surgical bed, or one of those real, hospital professional beds for a while in his home, with the oxygen and everything that was necessary. So what level of delivery of services can you do? Like, for example, obviously medications, DME equipment, obviously you can do that. Is it like, do you have to have a special license for oxygen, for example?
For oxygen, I don't think so, but I know with some of the needles and some of the controlled substances, that's where you have to really be careful. I do know that right now we're in process of getting the nuclear license. So that's going to be a big one for us. I think that's going to open a lot of doors. And I think that's where the money is as well.
All right. Now that you've been in this a while, you and your team have several advantages. One of those advantages is the fact that your team understands pharmacy internal operations because you have another sister organization that helps to offload tedious tasks in data entry and some of the things you guys are doing. That's a huge education to the organization. Talk to me about what you've seen from a perspective of revenue, of talking with pharmacy owners who are implementing this and how it's making an impact on their business.
Absolutely. I've come across a lot of pharmacies that switched to RX or route from majority of different pharmacy managers for a majority of different delivery systems. And the feedback that I've been getting from them is that the software RX for route is literally pays for itself. I've seen pharmacies reduce the amount of in-house employees because everything is so automated. The way you could put it and think is us calculating something manually. Let's say it's just the numbers, right? You have 14-day cycles, 20-day cycles, 30-day cycles, doing everything manually, finding what's efficient compared to doing everything to a calculator, to the computer, where everything is just calculated for you. It's unmatchable. I've had some feedback from one of the pharmacies actually that if for instance their pharmacy management system decides to switch to a different delivery system, that they will rather switch a pharmacy management system than switch their delivery system, which is RX for route. I think that's one of the best feedbacks I've received so far.
That's awesome. If you're watching us on YouTube, watching us streaming live on LinkedIn, you'll see kind of like this graphic. It shows kind of how things are working to bring this to operations, to workflow. Talk to me about the delivery of the medication. You have some kind of app that you're using to get the patient to either sign off on something, but talk to us about that a little bit.
Absolutely. All drivers will have an access of the mobile app that is available on the App Store or Google Play Market. You don't have to download it from any of the third-party shady websites or anything like that. Everything is official, verified by Google, Apple. That app is fully HIPAA compliant and it's fully SOC 2 certified. With this app, the drivers are able to collect the signatures, look at all the delivery information, take pictures of the delivery, mark deliveries as completed to the nurse, put any special instructions, nurse names, anything you would want to see in there. And everything is real time. That's another best thing regarding RX for route. You don't have to wait for anything to be uploaded. You don't have to come back to the pharmacy to upload the signatures or anything in that way. And even if there's no connection, our system, our mobile app will still work. Once it's connected to any network, the signatures and the pictures of the delivery along with the date stamp will automatically go back to your pharmacy management systems. It's not 2004 anymore. Most of the pharmacies management are open. So we are able to receive and extract any data alongside.
All right. So let's talk about temperature. We hear horror stories about mail order pharmacy dropping a 90-day supply or whatever into the mailbox, and then it just cooks the medication, and no one really. It's a commodity environment. I hate it. I think that they should do away with the majority of our mail order pharmacies and move more to the independents. Or actually, I used a term probably 10 years ago called mail service pharmacies, and I think that independents could become mail service pharmacies where it's concentrating more on the holisticness of the patient in engaging them in mail. But I think moving them to an RX for route relationship is going to be better for the profitability of the individual account because of vitamin therapies, because of suggested therapies for other things that you could deliver. So talk to us about temperature. Talk to us about like getting the patient to know that that their medication is delivered and is there?
Absolutely. So for any of the refrigerated items, there is a special procedure that comes alongside within the app. And how it works is we get that information directly from the pharmacy management system. You don't have to input anything manually. So as long as your pharmacy management system knows this is a medication that needs to be kept in the refrigerator, we get that information and we pass it along to your drivers, right? And during the transportation, until that package is delivered, the driver will have to take a picture of this medication being located on the cool box alongside with a picture of the thermometer. And same thing at the time of the delivery as well, making sure that he proves to you, to the patient, that throughout the whole time the medication was in fridge. Here's the pictures for every 2 hours with the correct timestamps, as well as on the delivery. This was the temperature. This is how it looks like with the patient's picture on the background. Everything is nice and neat, as it should be.
I like it. I like the assurance. I think it's a marketing opportunity. I think it makes your pharmacy look 10 times more professional when it's like using this same format, the technology of the app. People get used to using it, and then the communication back to the patient through texting, through pictures, through whatever else is tied into it. But this is exciting. So multi-site conference, NCPA, that's going to be in Naples. So you have to drive. How far away is that? That's only like
That's
2 feet, right?
That's 4. That's 3.5, 4. But the ride should be nice. I mean, especially
get out of here with your Florida weather. I'm here in Pittsburgh, and it's muddy and it's cold, and I don't like it. And you guys went from where to where? New Jersey to Florida?
From New Jersey to Florida, yes.
What part
That's a
of
big
Florida
switch.
are you guys in now?
We're in Fort Lauderdale now, and it's nice. I mean, I'm sure you could see the weather. It's sunny outside almost every day.
Hey, listen, if you are a pharmacy owner in the tri-state from Florida, it might be quad state, actually, it might be 4 states that attach. Make a trip down to their offices, make a time to spend some time with them, ask lots of questions. They kind of could develop kind of a work lab for you for a day down there to really go through the system, how it's going to impact your pharmacy, do some demos, do some rollout of the marketing of this system. Because if you market this the right way, it's going to make your pharmacy look like a freaking champion and really take advantage of our technology and engagement. But I think, Doni, this is more about the relationship between the pharmacy and the patient at home, making them feel like, listen, you're not able to get out. We got your back. We got your emergency services. We got your vitamins. We got other things that are coming from our stores. I think it's a big opportunity.
No, absolutely.
All right. Well, we are excited to see you at upcoming conferences and spending some time with you and your team. Love going to dinners with you. You guys are wild. I love it. Love hanging out. So
Of course.
see you at an upcoming conference.
Yep. Work hard, party hard.
That's right. I like that motto. Hey, we'll be right back with more TWIRx.
This episode is sponsored by Independent Pharmacy Cooperative, widely known as IPC. Established in 1983, IPC is the nation's largest group purchasing organization owned by independent pharmacy. With a mission of maximizing the success of community pharmacists, IPC works to provide members with access to effective programs and services designed to enhance profitability for independent pharmacy. Read more about our mission by checking out our website at ipcrx.com. That's ipcrx.com.
Hey, welcome back to TWIRx. We're here on Friday. It's so good to be Friday. It's good to be Friday. I actually am working over the weekend. Kristen, I don't know if you have any big plans this weekend or not, but I'm working.
Yes, I don't have too many yet. We'll see what the weather brings.
So I'm going to be going to the Pennsylvania Pharmacists Association annual conference, and it starts today, later tonight, and then
will go through Saturday, and it'll just be the gathering of, I call it the Super Bowl of Pennsylvania pharmacy, and it'll be a good time to. I like the smaller conferences sometimes than the gargantuan ones because sometimes it's better communication.
I agree.
Yeah. So you are the guest today on TWIRx. Excited to have you, Kristen Hutchison. Tell our listeners out of the gate, like, what do you do? How are you tying back to patient advocacy and policy and clinical research? And just give us a little of your background.
Yeah, well, great. Well, it's nice to be on the podcast. Yeah, my name is Kristen Hutchison. I live over in Minneapolis. I recently completed a master's in health policy and law, and I come from a background of medical writing and research. I've done a lot of my own consulting work in clinical medicine, especially on the side of systematic literature reviews, in looking at patient outcomes based on different devices and pharma agents. And I also have a background on patient advocacy side, working in a lot of different chronic illness spaces and organizations, doing federal lobbying and some state lobbying as well.
Yeah, the changes that are happening right now in PBM reform is accelerated. We were talking about it. We launched the PBM reform podcast in 2019, and it was slow go. Like it was, I mean, staging and trying to get something done, and staging and more meetings, and it was just like, there's lots of people, pharmacy owners and people in like Pharmacists United for Truth and Transparency, and all these organizations were like, we were really getting exhausted. And now, over the last 18 months, things have really accelerated. And people like State Representative Auchincloss, who bring so much attention to, he's very good at articulating in a way that a 12th grade high school graduate would be able to understand, and being able to break it into pieces, because that was some of the tricks of the big three PBMs is let's keep changing rebate and formulary role, and let's change this and this, and it was so confusing. Now we're starting to break it into categories, and it's starting to become much more attackable. That's not even a word, but
Right.
being able to attack the issue. And
Right.
and you and I kind of before we started talking was like, okay, so what's next? And the big next thing that's going to be happening, we'd like your insights on, is the bipartisan breakup of big medicine, the Big Medicine Act that targets vertical integration in healthcare. And Doug Hoy, the CEO of the National Community Pharmacists Association, he testified, and he's like, to have a physician working for a health system that overrides what the physician has prescribed just because they're making more money on it is
Right.
ludicrous. Insurance companies should not be making decisions for our livelihood and our health. I want my physician and I want my pharmacist talking to each other, and whatever they decide, that's what I want to go with, and that's who I want to
Right.
trust, not pencil pushers.
Right. And I think a big part that we don't talk about too much is that when patients go into the pharmacy counter, they will get, the price tag on their medication, and they think, oh, this is the pharmacist's fault. When in reality, as you're
Yes.
saying, there's a lot happening behind the scenes that is taking down the autonomy of pharmacists and physicians, I mean, healthcare providers in general. And so we're kind of trying to look higher up on the ladder on like, where are these prices coming from? And it's really not the provider's fault. So I think that's important.
It is. It's to know we have technicians who get screamed at. We have pharmacists who get screamed at, and
Right.
and people shouldn't be acting that way anyhow, regardless of what's going on. But the patient is under the impression this is this individual with that computer system, and they're just trying to gouge me or make more money, or my copay changed. The consumer has zero idea. We started talking about PBM reform in 2019.
Mhm.
I will admit it took me probably 3 years to really understand the parts of the engine that was a PBM. And then by the time I learned it, new elements came out of how they were keeping more of the rebate or negotiating with pharma or going to the TPA to kind of negotiate at different levels. And then
Right.
they gave specialty pharmacy a bad rap because now politicians who don't understand that there truly is a difference between a specialty medication therapy regimen, not necessarily the actual medication, right? Or not necessarily the science, but if you're on a certain medication and you have to be checked on day 10, day 20, you know, what's happening to you at day 35. I mean, there are therapies that it's physician and pharmacists that are like, listen, this is such a delicate situation that this person's in with cancer or some kind of titration from one drug to the next drug. Like, specialty is real. It's a real part of, and everybody's like, oh, let's throw that into the bucket of, that's just a PBM tactic. Well, guess what? PBMs did use specialty pharmacy as a way of gutting the system of more revenue. And, you know, shame on them for messing up a whole sector, giving a whole sector of pharmacy a bad rap.
Right. Yeah, I think I could share a more patient story on that, on specialty pharmacy. So
Yeah,
I personally have
biosimilar.
ulcerative, yes. So I have ulcerative colitis. I've had it since 2009. I would say now it is the hardest I've ever worked to stay on a medication that will keep me in remission. So I speak about this with a lot of different patient advocates. If you're on, you know, one of these higher retail price drugs, Stelara, Humira, you know, one of these kind of blockbusters essentially for the PBMs, they're kind of throwing you off and making you try a biosimilar, which has a lot of ramifications for patients who you know, have a condition that will flare if you switch medication. It doesn't work as well. There are a lot of potential side effects, things like this. And so for patients to speak with specialty pharmacists in these appeal processes, I think that's what's something that's important to put a spotlight on, because these pharmacists are essentially writing prior authorizations, they're writing the appeal letters. The bulk work that they're doing is speaking with the patients and fighting on behalf of patients. And every time I speak to another pharmacist, I think, did you go to pharmacy school to write PAs, you know? And
Yeah.
so it's really unfortunate. I'm sure you talk to a lot of pharmacists on that side, but the patient perspective, I think, is like, you know, we've never had to work so hard just to be stabilized. And the work that I did in my master's program on my capstone research was about PA legislation at the state level. Because as we know, ERISA is much harder to kind of get in and work around at the federal level. So I was looking at Minnesota state level and looking at, you know, turnaround times, how quickly the PA needs to be turned around. And there are a lot of different legal loopholes that, you know, health insurers and PBMs are getting into. But I think the kind of humanizing factor of these prior authorizations, all of the administrative work that's happening on the specialty pharmacy side, plus the patient side. I mean, these are hours and hours. These are full teams of people that have been hired just to do PAs and do appeal letters. And so what's happening kind of consequently is there's an entire market now with companies like Claimable, Counterforce Health, a lot of other free options that are helping patients write these appeal letters. And so I just, as a patient and a health policy researcher, I've never seen such work go into keeping patients stabilized and essentially reducing medical care. Because if patients are not stabilized with their medication, they will require more medical care, which produces more costs. So we're trying to do some type of preventative medicine here and keep patients stable, which will save costs in the long run, which I don't think is really spoken about that much.
So we know several things are taking place. This week in pharmacy, Buchanan Ingersoll published a blog that said sweeping PBM reforms arrive, what the 2026 federal legislation means for pharmacies, patients, and employers. And they do touch on House Bill 7148 and a large, when they always say sweeping or like large, I like things to be as definitive and definition driven as specific, so that the PBMs can't get away with being too obscure in certain
Right.
subjects. But what
Mhm.
have you kind of read on this and where this could lead, or what dominoes fall next?
Yeah, I think this is a really prominent time in PBM reform. I agree with you that, the past few years, I've seen a lot of bills go into circulation and die on the Hill, especially like the Safe Step Act. We've been trying to get that passed for years, and it's kind of gone nowhere, personally speaking. I think the Vertical Integration Act that was just presented is kind of a reflection of the hearing that happened on, I believe, January 22nd
Mhm.
with the health insurance executives, the 6 different insurance CEOs. But I do think that that hearing was very pivotal. However, there have been multiple hearings in Congress. Last year, I know July 2024, there was a third part of the series that was talking about PBM transparency, and we talked about spread pricing, and all 3 of the panelists committed perjury. They got a letter from Comer, threatening them with jail time, but that part wasn't talked about too much. So I think that personally, as a patient advocate and policy researcher, I've seen PBM reform even at the federal level. 2 years ago, I was there with Infusion Access Foundation, and I spoke to quite a few aides, and they said, PBM reform comes in these packages. As you're saying, sweeping PBM reform will get put into a package, and then all of a sudden, oh, it disappeared, in that package, it
Yeah.
was removed. And I have a lot of feelings of why that happens, but I think that, it's been kind of this transparency, uh, kind of glamorized word of, oh, we just need transparency and that will solve everything. So I do think that this push on, this recent testimony a few weeks ago has led to this awareness of, oh, this vertical integration, as you're saying, specialty pharmacy is feeding on the other part of the supply chain. It's such a closed loop where they're profit seeking behaviors on every step. If we break down, one of those and really illustrate it, for example, step therapy, if we're looking at reducing the forced switching, non-medical switching that's happening, I think that's one great area that we can really improve patient care. I think we can improve provider care and reduce administrative burden. But, those need to be played out specifically in the bill appropriately, um, to actually make an impact and not to have kind of these fancy words of, oh, just increase transparency, right?
Yeah, exactly.
Yeah.
It's it's so um, it's so frustrating when you see independent community pharmacies going out of business
Mhm.
because um, of them not even being able to make, payroll or being able to pay their bills, or and
Right.
and then so many people go without pharmacy care because
Mhm.
of those policy, or because of the way that a business runs, because of, and it really has very little to do with um, it has extreme, so much of it is just tied to profit. It's just about the profit, and non-medical switching
Right.
um, is a prime example. It's one piece of PBM reform, but it's the
Right.
one piece that is glaring to me. I know
Right.
Bill Schmitnick. I've met him. I've spent time with him. I've heard his
Mhm.
story about Cole passing away. This was because
Right.
of the non-medical switching. This
Right.
was changing this boy's inhaler, this man's inhaler,
Mhm.
from one product to the next, just because of the PBM being able to make more money.
Yeah.
And this is finally coming to light that this is because of, it was the Advair, like is showing on the screen. So it's
Mhm.
like, okay, he was gonna pay $66. Great, that's what he budgeted. Nope, it was
Right.
$539, and he's like, I either have to pay my rent this month or I have to buy
Mm.
my Advair. I don't even have the money in my bank account. Therefore, I have to leave the pharmacy without my Advair. And he went home not knowing that he was going to have a massive attack. He has an attack.
Mhm.
They take him to the hospital. because the ambulance was called and he passes away. And I'm like, that was completely avoidable if you would have left it in place the way that it was supposed to be, notified the physician or notified the pharmacist if it was like an emergency thing that's like, hey, this guy needs this. Let's give it to him and we'll decide on Monday, or we'll decide, you know, in the next week what to do with the pricing. Well, that's what would have happened if Cole went to an independent community pharmacy, by the way, just as a little plug for our independents out there. If he would have went to an independent, it would have been like, independents have been like, dude, like take your freaking medicine, take it home.
Right.
We'll get we'll get the bills, we'll get this all figured out. Because the independents, they know, because it's their livelihood. It's not the pharmacist just at a CVS that's standing behind the counter that gets their paycheck no matter what. These independent community pharmacies are pretty freaking savvy about going after their money and getting things done. And that's sad. I mean, that's a perfect example of non-medical switching.
Right. I agree. And I met Bill, I think it was last June, when we were in DC with Patients Rising. I spoke to him for quite a few hours because, I mean, I don't think the human cost is seen enough when we're talking about policy. And I do know that Buddy Carter down in Georgia, he will highlight a patient story when he speaks, you know, during these hearings, when we're talking about PBM reform. And unfortunately, I've gotten jaded to the point where I think, you know, these lives are being lost and things are not changing. So personally, you know, there's another case I know of a friend of mine. He's an attorney and his son was taken off of Remicade for his Crohn's disease. Remicade was keeping him in remission and he was completely stable. And, you know, there's a lot of legality behind this if we're looking at a corporate practice of medicine. And I think that that is also a part that needs to be discussed more, as you're talking about, you know, physicians and pharmacists are getting less and less autonomy, and these corporations are doing these quote unquote peer-to-peers with, you know, maybe a physical therapist, someone that has no idea, you know, what the training is like to be able to prescribe these meds. And so I think just generally the humanization of patients and providers is really key when we're looking at policy reform, and getting those stories out is part of our goal, my goal at least.
I tell you what, I've heard of Patients Rising. That was a group. I mean, that's been around for a little while now, and their advocacy to get patients' voices out is pretty powerful. Are you part of a specific chapter of Patients Rising?
Yeah, so I've gone to DC with them twice to do a day on the Hill. We go in June, and I'm part of the Patient Senate, which is an organization that's looking to increase their impact essentially at the state level. So right now we have the fly-ins. We do a little bit of work on the back end through local and state level legislation. I know Bill does a lot in Wisconsin, for example. But we mainly go, and last year we talked about the Copay Accumulators Act. We talked about the Safe Step Act. I decided to bring up the No Upcoding Act, because I felt like that was an important part if we're discussing fraud, waste, and abuse. You know, the upcoding that's happening in Medicare Advantage. Like you said, though, I mean, there are so many areas to look at in PBM reform that staying specific, I think, is important too.
So when you think of this from different lenses, and sometimes you have to. So I look at things from the health system perspective, the hospitals that are out there that are serving their communities, the independent community pharmacies, the pharmacies that are more like Publix or Giant Eagle here in Pittsburgh, which is more of the grocery store chain environment. It's so interesting. I've been doing this now for 17 years, documenting the entire profession through podcasting. And I've noticed that patients get treated differently in each of these, you know, elements, different sectors. And it's like the white glove approach is the specialty pharmacy environment where they're getting a counselor, a pharmacy tech to help you with your account management, a
Right.
chief pharmacist that's dialing into the actual treatment,
Mhm.
follow up, patient assistance programs that are given to you and told to you, counseling and together with your family. And now you're coming on a Zoom or you're going in person, and like this. Wow, it's like, wow, this is the way that we wish we could all be treated like this in pharmacy. And then you go down to fast food out of the CVS, down on the on the corner of expensive and pre-authorization, and it's like
Right.
you're treated like a fast food burger that let's just turn out as many burgers, as many prescriptions as we can, because we have to stay in business because of the way that this system works. And I'm just like, no,
Right.
like there's a balance between those two environments, and people treating people, number one, with dignity, and knowing that we're talking about healthcare. We're not talking about burgers and fries. We're not talking about a car sale. We're not even talking about the biggest purchase that most of us will ever buy is a house. It's not even a house transaction. This is like our living. This is the way that we function as human beings for longevity and happiness and healthiness. And it's just like, come on, like the radicalization of healthcare couldn't happen at a better time. People like you, people like that are running We the Patients, and Matthew Zachary and Mark Cuban's influence, that all of that is finally, Jake Auchincloss, we're finally getting to a position in my 22 years in healthcare where I am seeing faster changes, and I'm seeing impact, and I'm seeing things happen. However, we have to stay vigilant and creative to stay ahead of the next big insurance company building a new model where they're going to stay compliant, and they're going to, these new federal PBM laws are going to come out. They're going to break up the vertical integration. And then these big organizations are just going to rise again in some other element to take control of the money. And I'm just like, so how do we keep that from happening? Like, how do we always bring it back to the physician, pharmacist, and patient to keep that triangle, tight as possible? And I don't know what the answer to that is.
Right. Yeah, I agree with you. I think when I was in DC last, we worked with Heart Health Strategies, which is a lobbying organization, and all of these patients showed up, and we're out there at the federal level talking about our stories and sharing all of these very emotional things with aides, legislative aides, and I truly think that this reform, PBM reform, is the most bipartisan area of legislation that seems to, have agreement on both sides. And I think that that is something that gives me hope, definitely, to be able to see. I think it was a Republican congressman saying that his medication was denied 8 times after he had brain surgery.
I remember that.
And when I heard that testimony, I thought, wow, how much further are we going to let this one go? Because that is something that patients, that are not in Congress have been dealing with their whole lives, and a lot of lives have been lost. And so hearing that, it's like something needs to change. And I think that the further, things are going, the more, I guess, more big of a change we need to have. But then I agree with you on the side of these organizations are so big, for example, the GPOs that are happening, abroad, that people are just kind of learning more about, and how these companies are kind of shell companies just to make more money. I mean, it's like all of the industry is kind of insidious on itself, but I do think there are a lot more of us that are kind of saying, hey, this isn't working for people and the human lives that are being risked and put into danger because of these industry kind of quote unquote standards. I think there are a lot more of us that are kind of speaking out, and I think that's really important.
Bravo. Absolutely. And writing, reporting, dissecting, digging into the details, that's how we're going to make changes. Because if we can use the data and the reporting and the information against the beast that is the macroeconomics of healthcare, then we can really refine and really, like you were saying at the beginning, is specificity is pretty important in this stuff, because
Mhm.
the big giants don't want to lose that revenue, and if it
Right.
means inventing a whole new beast, I'm already seeing it happen. We're already seeing talk
Right.
about personalized medicine and blah, blah, and I'm just like,
Mhm.
please, like, where were you guys
Yeah.
10 years ago when we were talking about don't give this drug that is it's a black box warning on the FDA's site where it says pharmacogenomics. It's like these top 200 drugs don't even work the way they're supposed to 50% of the time. You better get a
Right.
PGX test to even figure out if you're going to metabolize it the right way, because there's a 50% chance that this medication will not work for you. Well,
Mhm.
why isn't that taking into consideration to start saying to the drug manufacturers, hey,
Mhm.
you now have to manufacture 3 different types of the same exact medication in order to help people ingest, and the efficacy to be as you hope it is. And I
Mhm.
would think that would be a pro for pharma, because then they can keep the patents longer.
Right. Right. Exactly.
All right. Well, this week
Yeah.
in pharmacy has been fun, talking with Kristen Hutchison. How do you like people to reach out to you? Are you a big LinkedIn user?
Yeah. Yeah. I'm on LinkedIn quite often. I also will do a full Substack analysis of the Vertical Integration Act. So I will put that there very soon so we can kind of dig into that specificity and see what's being presented. So Substack or LinkedIn would be great. I'd love to talk with other folks in this field, David versus Goliath
Yeah.
field.
Well, Kristen's link to LinkedIn will be in the show notes, so take a look. Kristen, make sure that this is not the last time that you're going to show up on This Week in Pharmacy.
Yeah, great. Thank you, Todd. It's been really great.
Hey, this has been a wonderful day to share with you listeners. Thanks so much for listening. If you're listening on Apple, Spotify, if you're watching us live on LinkedIn or YouTube, it will really help if you share an episode that means something to another provider, to a nurse that you work with, a pharmacist you work with, a pharmacy technician, to let them know that things are not sitting still. And if you're on the sidelines and you're frustrated, we're frustrated too, right along with you. And people like Kristen are documenting and helping to refine and helping to bring more focus to it. So thank you so much.
Thanks.
All right, we will talk to you next time on This Week in Pharmacy.